discover that there is abrupt decrease in the FEV1. The FEV1. How would you subclassify that pulmonary disease? Obstructive, acute obstructive. And let's say you have a 5-year-old man. He has a history of being an insulator, and he insulates homes. He presents with a 1-year history of dyspnea. We do some studies, spirometry, to discover there is this decrease in the FVC. How would you classify that? Chronic restricted. Okay. And if he's an insulator, he probably has been exposed to asbestos. He probably got asbestosis and something like that. We're going to talk a little bit about that too. Okay, so that's the way you want to be able to identify these pulmonary diseases, be able to subclassify them immediately as either obstructive or restrictive, and then think of all the diseases that are classified as obstructive and restrictive, and then further analyze whether the condition is acute or chronic. Okay, there are certain diseases which are acute, certain diseases which are chronic. Okay. So we finished up with these different major types of pulmonary diseases last time. Now we want to get into something a little different. We want to take a look at some vascular diseases of the pulmonary system. Most of the time we're discussing vascular diseases, we're generally referring to the systemic arterial system. But then we got a whole other arterial system on the right side, the pulmonary arterial system. So let's talk a little bit about pulmonary arterial problems. Begin with pulmonary hypertension. Most of the time when you speak of hypertension and you don't qualify it, people are going to assume you're referring to systemic hypertension. It's high blood pressure on the left side of the circulatory system. But of course, sometimes hypertension will develop on the right side of the circulatory system. It's comparatively rare when you consider the frequency of hypertension on the left side. Hypertension on the right side is relatively uncommon. However, it does develop in certain circumstances. Sometimes there are identifiable causes of pulmonary hypertension. Sometimes it's idiopathic. Sometimes it just seems to have no reason. It just develops. Now, there are a number of different risk factors associated with pulmonary hypertension. Sometimes the pulmonary arterial system develops an increase in resistance to blood flow. Remember, resistance is a factor in Ohm's law that determines blood pressure. Yeah, blood pressure equals cardiac output times resistance. There's an increase in pulmonary arterial resistance. There's an increase in blood pressure on the right side of the circulatory system. Now, sometimes the cause for that is identifiable. Sometimes it's not. Sometimes, for whatever reason, the pulmonary arteries overconstrict. It could be because they're overly sensitive to certain vasoconstrictors. Sometimes it's due to the fact that we're not producing enough vasodilators, or there's some sort of imbalance in vasoconstriction, vasodilation, and the pulmonary arteries overconstrict, and that causes increase in pressure. Another common cause of pulmonary hypertension, some sort of lung disease. Lung diseases affect the resistance of blood through the pulmonary arterial system. All of the blood from the right side of the circulatory system must go through the lungs to get to the left side of the circulatory system. And that means it's going to have to go through those pulmonary capillaries. If you have some sort of pulmonary disease, perhaps you're losing pulmonary capillaries. For example, emphysema, a good example of a disease in which you're losing alveoli and all of the pulmonary capillaries in the walls of those alveoli. That's going to reduce the cross-sectional area through which blood is passed from the right side to the left side. That will increase resistance to blood flow, and that could result in pulmonary hypertension, and often does in advanced cases of emphysema. Sometimes we can have recurrent pulmonary thromboemboli. Usually the source of that is the lower legs, the lower extremities, these deep leg veins. Sometimes people will have intrinsic hypercoagulability of blood. and they start making DVTs. These DVTs may not be big enough to kill anybody, but they generate, they develop in the lower extremities, break off, they go through the right side of the heart, and they become impacted in various parts of the pulmonary arterial system and gradually obstruct the pulmonary arterial system, and increases, again, resistance to blood flow and can cause pulmonary hypertension. Sometimes you have an increase in blood flow in the right side. This can occur if you have a left to right shunt. Some good examples of left to right shunt. Give me some good examples of left to right shunt. What could anything cause a left to right shunt? Atrial septal defect, ventricular septal defect. Anything else? How about patent ductus arteriosus? Patent ductus arteriosis. Blood goes from the aorta to the pulmonary system through patent ductus arteriosus. That can cause trouble. Okay, so you get more blood flow that way. Okay, that would be essentially increasing blood flow, cardiac output, and that would increase blood pressure on the right side. Excuse me.
Dr. Matty, can you just tell me what page you're on?
A what?
What page you're on in the notes?
What page am I at? 16? The about 1/3 of the way down the page. Assuming my pages match first. Okay. Well, those are some of the different reasons that one could develop pulmonary hypertension. There are certain diseases that are known to be very closely correlated with pulmonary hypertension. There is one disease that's called idiopathic pulmonary hypertension, which is a type of high blood pressure on the right side. Again, develops for unknown reasons that are not related to any kind of other disease that secondarily impacts the pulmonary vascular system. Let's take a look at that. That's a good example to go by. Idiopathic pulmonary hypertension usually is a disease that will affect a young, otherwise healthy woman. It certainly can affect men, but it's usually a young, otherwise healthy woman. Whatever starts this pulmonary hypertension, the fact that the person has this high blood pressure on the right side causes structural changes to occur in the blood vessels. And eventually what happens is the blood vessels start losing cross-sectional area. That increases resistance to blood flow. And eventually the condition becomes irreversible. You have this very high resistance to blood flow, increasing blood pressure. No matter what you do, you just can't get the pressure down on the right-hand side. Let's take a look at some of these structural defects that develop as a result of pulmonary hypertension. This can occur for any kind of cause of pulmonary hypertension. Let's take a look at a normal blood vessel. So here's a normal blood vessel over here. Normal arterial, normal proportions. You've got the lumen of the blood vessel here getting filled with RBCs, and there's the wall of the blood vessel right there. Everything is in proportion. Good looking arterial. Everything looks good here. Here's an example of what an arterial from the pulmonary system might look like in the setting of pulmonary hypertension. Okay, you've got the lumen of the blood vessel there. There's the wall of the blood vessel. You can see that the thickness of the blood vessel wall in proportion to the diameter of the lumen, those proportions are wrong. You shouldn't have a very small luminal diameter here in proportion to the thickness of the blood vessel wall. That's going to cause this blood vessel, of course, to be stenotic. And as a result, resistance of blood flow through that vessel is going to be extraordinarily high. Now, again, whatever starts causing the pulmonary hypertension, eventually these changes start to occur in response to the pulmonary hypertension. And eventually what happens, you get all these anatomic changes in the blood vessels in the lungs, and the condition becomes permanent. The person has permanent increased pressure on the right-hand side. Now, sometimes these changes in the blood vessel wall architecture become so bad that the blood vessel lumen actually occludes. Let's take a look at this. Here's an example of a pulmonary arterial that has almost completely occluded. And you can see it's a section through the lung. We've got alveoli here. This is the blood vessel right over here. If you take a look within the blood vessel, you can see its lumen is almost completely obliterated with cellular material. These cells consist of smooth muscle cells that reduplicated, elastic lamina that is reduplicated. All of these changes have occurred in response to the high blood pressure. These are the structural changes that occur in response to the high blood pressure on the right side. We get this complete proliferation of cells, and the lumen is completely obliterated. The only thing left are these small little cannulae that you see here. Over here, small little cannulae. This is referred to generally as a plexiform lesion. Plexiform lesion is refers to a blood vessel that's almost completely occluded, except for the presence of these small cannulae. And again, this is the type of changes you see in association with pulmonary hypertension. Now, it's very difficult to treat pulmonary hypertension. Once it gets to this stage, there's really nothing you can do to reduce the resistance of blood flow through the pulmonary arterial system. Normally, if someone presents with systemic hypertension, you give them antihypertensives, all kinds of different antihypertensives you can give them, diazide diuretics, vasodilators. There are just a variety of classes of different antihypertensives that you give, ACE inhibitors, ARBs or angiotensin receptor blockers. There are just many different classes of systemic antihypertensives. Sometimes that's effective, and sometimes that's not, reducing systemic hypertension. However, if you try to treat pulmonary hypertension with those same antihypertensives, they don't work at all. And here's the reason. How do you do anything with a blood vessel like this? This blood vessel is almost completely occluded. You can't vasodilate it. It's not going to help. How would you even treat something like this? The answer is you really can't. With these types of anatomic changes, there's really no way to treat the high blood pressure on the right side. Now, the high blood pressure on the right side does present with a number of symptoms. Usually the symptoms are associated with reduced cardiac output. People will experience things like dyspnea and fatigue and exercise intolerance. And that is because the right side of the heart is having a tough time getting blood through these pulmonary arteries to the left side of the heart. So the left side of the heart can deliver blood to all the end organs. And as a result, people will present with symptoms consistent with a low cardiac output, again, fatigue, exercise intolerance. Okay. Now, very often, if these people are going to succumb to the effects of pulmonary hypertension, it's usually going to be because of right-sided heart failure. They'll develop some form of cor pulmonale, usually some sort of chronic form of cor pulmonale. When we conduct an autopsy and examine the pulmonary system, we find something that's virtually pathognomonic for pulmonary hypertension, and that is atherosclerosis on the right side of the circulatory system. Now, atherosclerosis is very common on the left side of the circulatory system. You see that, you wouldn't give a second thought about it. But we rarely see it on the right side unless it's caused by pulmonary hypertension. Let's take a look at that. Here's an example of atherosclerosis on the right side of the circulatory system. A very uncommon finding, except in cases of pulmonary hypertension. Here is a section through the lung. You can see some airways here with their thick walls. Here's a blood vessel right here. It's the pulmonary artery. You can see the luminal wall of the pulmonary artery here. Over here, it looks pretty normal. Smooth, shiny, and glistening. Over here, you can see this kind of yellow plaque-like material. That's an atherosclerotic plaque. And when you see that in the pulmonary arteries, it's kind of unusual. Most of the time, you do an autopsy, if the person's got bad systemic arterial atherosclerosis, you very rarely see it in the pulmonary arterial system. When you do see it like this, your immediate thought is going to be, oh, this person must have had pulmonary hypertension. Pulmonary hypertension causes these atherosclerotic plaques. Okay. Again, presentation for this is fatigue, syncope, exertional dyspnea. Again, those are associated with reduced cardiac output. Sometimes it becomes cyanotic. Again, usually death occurs as a result of heart failure. It's very difficult to treat a disease like this. If you are going to treat a disease like this, you usually have to do an entire lung transplant. There's very little you can do to reverse the structural changes in the blood vessel once they've occurred. And there's really no medication that we have, no antihypertensive we have, that can really treat this very well once those structural changes have occurred. Workup, of course, we're going to see atherosclerosis in some of the blood vessels. The blood vessels will be remarkable for those architectural changes. You get hypertrophy, reduplication of the internal elastic lamina, and also smooth muscle cells in the wall of those blood vessels. And that's why you see that increase in the thickness of the blood vessel wall, possibly leading to complete obliteration of the lumen. Okay, any questions on that? Anything? All right. I'm going to go on to pulmonary infections next. Kind of important topic to discuss. About 1 in 6 patients are going to die from some sort of pulmonary related infection. So it's a significant source of mortality. So we're going to take a look at it. Now we're going to begin with looking at some definitions of words. There are certain denotations words have, and then there are certain connotations words have in medicine. In medicine, I've never seen so many variations in the definition of a word. Now, sometimes clinicians make up their own kind of definitions. They make a lot of assumptions about a definition. That's what I mean by connotation. There's a very specific denotation of word. You look up in the dictionary. Then there's a whole other meaning that a clinician might assign to the word. So we want to understand the denotations and its connotations so that you don't get confused when you're in a conversation with a clinician. Okay, let's talk about the word pneumonia. Okay, that just means inflammation of the lung in and of itself. It doesn't even necessarily imply the etiology. Okay, the word pneumonia just means inflammation of the lung. However, connotation, very different. When you say the word pneumonia, you don't qualify it. People will assume that you're referring to some sort of inflammation of the lung of infectious etiology. Usually, they will assume that it's an infection involving typical bacteria. Typical bacteria. You know what I mean by typical bacteria versus atypical bacteria? Microbiology.
That's our strong.
You're strong.
Yeah.
Okay, well, just briefly. Okay, typical bacteria. These are bacteria like Streptococcus pneumoniae and Klebsiella.
Yeah.
All right, so just drawing things. Let's take a look at typical bacteria. Okay, so typical bacteria, you know, kind of big in comparison to atypical bacteria. It's well, let's put it on the scale of, you got about 1 micron over here. Okay, maybe there's 1 micron right there. 1 micron right there. Okay, typical bacteria, it's a prokaryotic cell, it's got a nucleoid, and it's got a membrane and a wall here. Basically, it can support its own metabolism. It exists extracellularly. And most of them exist extracellularly. They can support themselves. They don't need to parasitize the metabolism of any host cell. They can grow on their own. They're just fine. Okay, and then you got these atypical bacteria. They're much smaller, okay, and much simpler kind of prokaryotic cells. Okay, they have a nucleoid, they have a membrane, they may or may not have a bacterial wall. Okay, because they're so small, they're simpler organisms, and some of these organisms have to parasitize a host cell's metabolism in order to survive, and so sometimes they're actually obligate intracellular parasites. They're not viruses. They're bigger than viruses, but they are much smaller than typical bacteria. Good examples of this might be mycoplasma and maybe mycoplasma is a good one. Okay, good example of an atypical bacterium would be the genus Mycoplasma. Okay, now, when you speak of pneumonia, again, and you don't qualify it, clinician's going to assume that it's an inflammation of the lung of infectious etiology, probably caused by typical bacteria, okay, like strep pneumo, something like the streptococcus, pneumococcus, right? That's a typical prokaryotic bacterium that can cause pneumonia in the lung. Okay, it's a very kind of nasty type of pneumonia. With these typical forms of bacterial infections, usually what results is an exudate that collects in the alveoli. All the alveoli fill with pus. And when you have these typical bacterial infections, you get a very nasty type of pneumonia. And all the alveoli start filling with pus. The air is no longer present in the lung. If you look at a radiograph, the areas of the lung that are infected are extremely densely consolidated, very opaque. Because there's lots of pus in the alveoli, people are coughing up a lot of sputum. And again, because the lung's not properly aerated, well, people have trouble exchanging gases, oxygenation. Usually they're bedridden. They can't really walk around very much. They're usually confined to bed. That's an example of a typical bacterial pneumonia. Okay? Lots of profound symptomatology, coughing up a lot of sputum. Basically, you get airspace disease. There's lots of pus in the airspace. Because of that, you're coughing up a lot of sputum. Sometimes, however, you can develop infections with these atypical bacteria. Atypical bacteria don't cause airspace diseases. They typically cause inflammation of the interstitium of the lung. Those are the walls of the alveoli. So the alveolar spaces, the air sacs, they're all filled with air. It's just that the walls are infiltrated with a lot of white blood cells. Okay, that's called an interstitial pneumonia because it affects only the interstitium. It's also sometimes referred to as an atypical pneumonia. An atypical pneumonia, very often caused by mycoplasma, chlamydia, or something like that. Some sort of atypical organism can be caused by a virus, even a fungus. Viruses, atypical bacteria, fungi, they tend to cause inflammation of the interstitium of the lung, not the air spaces of the lung. Now, a couple of consequences of causing an inflammation of the interstitium of the lung. The alveoli are not filled with pus. You're not coughing up sputum. You may have a cough, but it's usually a non-productive cough. You're not coughing up that pus because there's no pus to cough up. There's nothing in the alveoli. People with these atypical types of pneumonias, they still have air in the alveoli. They can still walk around. They exchange gases. They're not going to feel too well. Okay? They're not going to be able to expand their lungs as easy because the interstitium is inflamed, but they'll still be able to walk around. And as a result, these atypical bacterial pneumonias are very often referred to as walking pneumonias. Have you heard of walking pneumonias? Okay. That's what we mean by walking pneumonias. Infection by some sort of atypical bacteria, some sort of virus or fungus. Those will cause interstitial pneumonias or atypical pneumonias. They're pneumonias that are not so symptomatic. You're not coughing up a lot of sputum. Okay? You're not bedridden. You can still walk around again. You're not really run the marathon or anything, but you still will be able to walk around. So those are called walking pneumonias. So when a clinician says a pneumonia, unless they otherwise specify, they're usually referring to some sort of typical bacterial infection, which is very symptomatic. If they say something like atypical pneumonia, or perhaps an interstitial pneumonia, or even an interstitial pneumonitis, there's another word, they're referring to these types of walking pneumonias. Any questions on that? All right, having discussed that, let's take a look at the actual pathology. We're going to take a look at the difference between types of infections of the lung that cause airspace disease, pus in the alveoli, versus interstitial disease. Okay, let's take a look. All right, so these are the types of infiltrating patterns that we can have. And depending upon where there's the concentration of inflammatory cells, we can subdivide pulmonary infiltrates into airspace disease. That's where the alveolar spaces are filled with pus. People with that would be coughing up a lot of sputum, very symptomatic, probably bedridden. And then we have something called an interstitial pattern, where the walls of the alveoli are infiltrated with white blood cells, but the airspace is relatively spared. The person will probably not be coughing up sputum. If they are, very minute amounts of sputum, really not very symptomatic. Okay, they'll probably be walking around. That would be the pattern you'd associate with walking pneumonia. And sometimes, of course, we have mixed patterns. Sometimes the areas of infection are focal, sometimes they're more diffuse over the lungs. And let's take a look at each of these so we understand these terminology, these different terms. We're gonna take a look at the radiographic appearance of interstitial disease versus airspace disease to get a good idea of just how extensive the infiltrates are. Let's first take a look at a radiograph within normal limits. Here's a good one. Nice clear lung field, very lucent. Okay, you can see the hilar radiodensities here. Those are normal. You know it's there already. You got lymph nodes, you got major arteries, veins there. They cast a radiodense shadow in the hilar region. That's all normal. You can see coming from the hilar region, you got vascular markings. Okay, all radiating out from the hilar region. Everything looks good here. Okay, cardiac silhouette looks good. Okay, pulmonary artery good. The aorta looks good. Okay, lucency of the trachea, okay, even the diaphragm's good curvature, okay. The costophrenic sulcus looks good, no fluid in it, just a lot of air from the lung in there, and that everything looks okay. So that's what a normal radiograph or radiograph with the normal limits would look like in the lungs. Let's talk a little bit about what airspace disease is and what it looks like radiographically. So airspace disease is a condition where you've got a lot of pus in the alveolar spaces. Let's take a look first. Normal lung, here's normal tissue. Okay, you've got the airspace here. You got the wall of the alveolus here. Again, notice how thin the wall of the alveolus is. A very delicate architecture. There's where the pulmonary artery capillaries are. Pulmonary capillaries are right in there. Okay, and of course you can see that all of the alveoli filled with air for good gas exchange. That's what normal alveoli looks like. This is what airspace disease looks like. In a section through a lung, you can see the alveolar wall here, other alveolus wall over here. If you look within the airspace, you don't see air. You see pus, a lot of neutrophils and inflammatory cells within the alveolar space. Okay, a person like this can have a tough time with gas exchange. Gas diffusion capacity is going to be extremely limited because now instead of air in the sacs, now they got pus. They're going to cough that up. They're going to have an infection of the lung. This is going to be a pneumonia remarkable for airspace disease. They pus in the alveoli. They're going to be sick. They're going to have probably a high fever, and they're going to have a cough productive of sputum. Okay, that's what this is going to cause. This is what we call airspace disease. Now, you'll notice that when you have airspace disease, you've really replaced all of the air in the lung with just a lot of aqueous-based inflammatory infiltrate. You're going to see that on a radiograph. A radiograph will no longer be remarkable for lucency in the lung fields. Instead, you're going to see an aqueous radiodensity, a water radiodensity. So we've seen what a normal radiograph looks like. Here is what airspace disease would look like in a radiograph. Okay, we have nice lucency here in the left lung, nice and black. That's filled with air. But on the right side, you can see the upper quadrant here is almost completely opacified. It's almost completely consolidated. And that's because everywhere over here, within these alveoli, you have pus instead of air. And so you get solid opacification. That's consistent with airspace disease. There's no air in that part of the lung. Person will be coughing up sputum. Okay. Typical causes for airspace disease. Typical bacteria. Streptococcus pneumoniae. Klebsiella. All of those are typical forms of bacteria. Okay. Typical bacteria generally cause airspace disease like this. Yes.
This is the same as a low-bar pneumonia? Is this the same as a low-bar pneumonia?
We're going to talk about low-bar pneumonia. Low-bar pneumonia refers to a specific anatomic distribution of disease. but it is bacteria, typical bacteria that will cause things like lobar pneumonias, as opposed to bronchiolitis. Yes.
Would you ever see this disease throughout the entire lung, or would they probably dead if that was the case?
Assuming you have normal capacity, the contralateral lung, you can live with just one lung. The exercise tolerance is dramatically reduced. Anything else? All right, that's aerospace disease. What does interstitial disease look like? Well, first of all, interstitial disease is typically caused by atypical bacteria like mycoplasma, viruses, fungi. Okay, those are the agents that cause interstitial pneumonia or walking pneumonia. Let's take a look and see why it's called walking pneumonia. There's another section through the lung. Okay, again, you've got the alveolar space there, and there. And then you got the walls of the alveoli. And look how delicate they are. Okay, inside the walls of the alveolus, you get the pulmonary capillaries. Okay, this is what we call the interstitium of the lung. The wall of the alveolus is part of the interstitium of the lung. Now, when the lung becomes infected with a virus, or mycoplasma, or chlamydia, or some sort of fungus, the inflammation doesn't affect the airspace generally. It affects the interstitium, the wall of the alveolus. And the wall of the alveolus becomes infiltrated with inflammation. And so a person does not present with airspace disease. They present with interstitial disease. Let's take a look at that. That's normal architecture. Here's what interstitial disease looks like. Okay, section through the lung. Look, there's an alveolar space. There's another alveolar space. In between, you got the wall of the alveolus. Now look at the space. There's nothing but air in it. So that's artifact, but there's nothing really but air in it. Okay, this lung has air in it. It's going to be loosened on a radiograph. But look at the walls of the alveoli. Look at how thin it is down here. Look how thick it became up here. Why is it so thick? Well, you've got all kinds of inflammatory cells there. Macrophages, lymphocytes mostly. You know, chronic inflammation. That's a typical type of inflammation that's good for viruses, fungi, and of course, atypical bacteria like mycoplasma. The air spaces are unaffected, but the interstitium very much infiltrated with some inflammatory cells. Well, what would you expect to see on a radiograph? Well, a radiograph still is going to be remarkable for lucency in the lung fields. But because of the increased thickness of the walls of the alveoli, you might see some haziness and maybe some lines or reticular patterns. Okay, here's what interstitial disease looks like. Okay, look at this lung. Looks pretty lucent. Nice and black. Okay, lots of air in there. But if you look really closely, and you have to look very carefully, you can see these lines over here. And these lines are not consistent with vascular markings. There's a little haziness here too. And that's because there's a slight increase in the radiant density of the lung because of the increased thickness in the interstitium, the wall of the alveoli. That kind of streaky pattern, sometimes it's called a reticular pattern, reticular web-like. There's a little haziness there. You know, overall, you get the sense that it's just not black enough. What I would expect. It's hazy. Well, that's because there is an additional fluids in the lung. It's just limited to the interstitium. Most of the lung is still filled with air. Now, someone like this, not going to be coughing up sputum. There's nothing to cough up. But they will be dyspneic. They'll have a cough. The airways, lungs are inflamed, they'll have a cough. But the cough won't be productive of anything. There might be a little sputum, but not anything to speak of. Okay, and that's consistent with interstitial disease. This person's gonna be walking around, probably coughing, you know, but they'll be walking around. And that's what makes this a walking pneumonia or an atypical pneumonia. And again, Major causes. Okay, atypical bacteria, viruses, and fungi. Those are the typical causes. Be careful with that word. Those are the causes of atypical bacteria, walking pneumonia. Okay. Questions on that? Let's take another look at an interstitial pattern. Here's another interstitial pattern. Okay. Now you really can see streakiness, kind of hazy, streaky pattern. No area of solid opacification.
So the typical would be more bacterium than viruses.
Yeah, viruses, you'd expect this. If I asked you, well, what would chlamydia cause? Chlamydia is an atypical bacterium. And if I asked you Klebsiella is a typical bacterium. It's going to cause airspace disease. Okay, here's a comparison. There's airspace disease. Notice the solid opacification. Okay. Oop, going to be coughing up sputum there. Okay. Over here, interstitial pattern. Yes.
So I've read a couple articles on about the mask. Students being forced to wear masks for 2 years. You know, science behind it. Anyway, is that the uptick in pneumonia from these pointless things? Is that more typical or atypical?
Yeah, I've read some of those. I've read some of those studies. Those tend to be more of a typical bacterial infection. Okay. Yeah, I want to get rid of this mask as much as you can. Yeah. Wearing this gives me a headache. It's heavy. But I cannot wear a mask in my. And then there's also concern with developing hypercapnia, that's CO2 retention. People with kidney disease are having a problem because then the lungs and the kidneys work together to try to balance pH. And sometimes the lungs have to compensate by blowing off more CO2. How can they blow off more CO2 if they're just inhaling it? That's a problem for some. Okay, anything else?
Repeat what you found that's range in both.
Okay, so interstitial pattern. You see it, there's no area of solid opacification. This is solid white. You see how solid white it is? That's consolidation, that's air disease. And this is a kind of a streaky pattern, haziness. It's really not solid opacification. Okay, that's interstitial disease. And usually it's more subtle than that. Usually you look at a radiograph of someone with atypical.
Never too early to party.
Usually you look at these radiographs of interstitial disease, you can't see, where is the problem? It takes a trained radiologist to actually see the pattern. Sometimes you get a clue looking at the hilar ridges. The hilar ridges are kind of prominent. And that's because the lymph nodes are reactive to the infection. Sometimes that's your first clue. It's not actually the lung fields. It's actually the hilar lymph nodes you look at. You see they're all kind of puffy. Okay. All right. Anything there? Okay. Why don't we take a break there and then we'll start up again.